tell us your lecture, and we hope we can learn for you because you traveled a long way. Thank you.
Thank you very much for the kind presentation. And I'd like to first of all thank Professor Seventer, Professor Salti, and all the Congress organization for inviting me to be here today. It's a huge honor to learn with all of you and to share a little bit of our experience with the pulsed radio frequency in Brazil. First of all, I'll start with some basics knowledge about the radio frequency, just to make sense of everything we're going to discuss later. And we know the radio frequency is a generator connected by two electrodes, the active one and the dispersive, the earth plate. And we have the active one all isolated instead of its tip, and where we have the temperature sensor. And we can choose different sizes of active tip, 5, 10, 15, 20, depending on the target, on the kind of treatment you're going to choose to do. And when we are talking about the continuous radio frequency, the ablative one, we are talking about inhibition of pain using heat. And we know that the heat will promote coagulation necrosis in that area. And we can measure the diameter of that lesion as well with the bioheat equation. And we can act in that equation as well. For example, put in the tissue interactions when you have liquid circulating in your cannula, as it happens with the refrigerated radio frequencies. And you put the adjacent tissue more able to receive that electric field, and you have with this bigger lesions, bigger area of lesions. And when you are using the continuous radio frequency, we have to be aware about the time versus temperature, and not only how you're going to fly your needle to the target. So you have to pay attention about the temperature, because you don't want to go near to the boiling point, as you're going to have a carbonization of the tissue and no electric field will be useful for the cell. So using this kind of procedure, you just want to block the afferent. So when we are using this kind of procedure, we just want to block and to inhibit the afferent nerve from bringing the pain from the skin or the joint into the spinal cord. And of course, as both things in life, we have some advantages and some disadvantages for the procedure. The advantage seems to be the more effectiveness rate, the high pain relief rate, but we have as well some disadvantages associated with that, because we have more complications like neuronal formation, numbness, anesthesia dolorosa, interpretation pain, and other conditions. We know that those kind of complications can occur as well using the PRF, but that's why we have to pay attention to some adjustments to do it and about the parameters we are going to use. But with the continuous radio frequency, actually we have some limitations about the use, because we have to think, especially me as an orthopedist, I have to think about the chondral tissue or the cartilage. And with the heat treatments, we cannot treat those joints. The cartilage can support, can stand heat, and even motor neurons or mixed ones. So then, that's why I thought Professor Mendes-Luiter is so genius with his invention in 1998, because actually he brought to us the possibility to treat the joints and not only block them. That's the huge difference when you are thinking about using the PRF and the continuous radio frequency. So with this kind of treatment, what we are doing is just making a silent period, and we are cooling down the system between those active those active pulses. And we can adjust our parameters to make the treatment as well as possible. So we can, when we have a treatment using 2 Hertz, for example, or 5 Hertz, for example, we are using 2 pulses in 1 second or 5 pulses in 1 second. And between them, we can choose the pulse width. And we know nowadays that using a lower pulse width, we are experiencing no heat association with the treatment. Because you notice that when you use 20 milliseconds on pulse width, you may have some heat spikes. And that's not what we want when we are using this kind of treatment. So we know that this kind of treatment is associated with a huge mechanism of actions. We know about the neuromodulation action, the anti-inflammatory, controlling the interleukins, inflammatory cytokines like interleukin 1B, 6, TNF alpha, and putting up some inflammatory ones. So, but nowadays we are opening our minds, thinking about some antioxidant mechanism and even neuroplastic mechanism, as we have seen before with Professor Marshall. And the neuroplastic may occur, maybe putting down the release of ABL1, the huge release of BDNF when you have some neuropathic lesion, and even stimulating TRK receptors, we can see the possibility to increase the neuroplastic cascade inside of the cell. So, with this loss, we have the work of Professor Alexandre Teixeira in 2005, where he put a needle inside of a joint where you have no nerve surroundings, and he noticed a real good result with this treatment. And that puts our mind to think that the immune system has become the focus of that treatment, not only just the block of the vector. That's Professor Alexandre Teixeira. He's a very, very kind person, always available to help us whenever we need. And this is his paper he wrote with 6 cases, and he used for the shoulder, the knee, the sacroiliac joint, hydrocarpal for the trapezial, and adrenal as well, with those good results. After that, in 2010, we have a good review for those who want to go deeper in those mechanism of actions with the participation of Professor Menes-Winter, where he describes all those anti-inflammatory actions and neuromodulation action of the pulse radiofrequency. And more recently, we have that update review 2021. It's very nice and strong suggest for those who want to go deeper in those mechanisms to read this paper, because it brought to us in an easy way to understand how does it work. And actually, he divided the actions in nociceptive signaling, immune activity, and synaptic function. But nowadays, we are talking and adding some other actions, thinking about the antioxidative mechanisms and synaptic for neuroplasticity mechanism as well. And this is the work of a friend of mine, Professor Josino Brasil from Porto Alegre, Brazil. And this is a huge, important paper, because actually he brought to us with that how the cell can understand that electric field, and not just for human tissue, but even for plant tissue as well. And it's quite interesting because it seems to be that the pulse radiofrequency can organize in somehow the release of ROS, the reactive oxygen species, but in the oxygen atom, it spins in a better condition for the cell to use it in a triplet model. And that's Professor Josino Brasil. With our dear Professor Olaf Kohoff, we had the good fortune to be there last year in Amsterdam, learning a little bit of his huge experience with the pulse radiofrequency. And with that, with all those kind of mechanisms, we open our menu of indications. You know, we have a lot of possibilities to use this kind of procedure. So Of course, we are going to use that when we have some difficult clinical improvement after we try to treat our patient then as a standard mode, like an anti-inflammatory, immune relaxant, taking care nowadays about the exercises, diet, and quality of life, sleep, and everything. And all those kind of treatments will help as well the result of your treatment with the pulse radiofrequency or whatever other treatment you will propose to your patient. And some questions become in our minds. We know that the spine is not in those gold standard results with the pulse radiofrequency, but some papers and articles like that in 2020 start the same question. Pulse radiofrequency could be a viable therapeutic option for the lumbar facet joint, and we think so, and why not? I believe we have to make some adaptations, but we are facing some good results with that as well. So, and we can do it, the procedure, using the ultrasound as a guidance as well, even for the spine. We can see, it depends on the training, of course, but you can see there the facet joint, and you can see the transverse process down there, and you will find your medial branch between the transverse process to the facet joint. And you can go doing it, for example, like that. I started with the medial branch, and then you put your hand a little bit up and go lateral to reach the facet joint with the ultrasound with your camera. Or you can do it in a sagittal view. You just a little bit lateral from the spinal process, and you can see the image of the top of the hill and the valley. And this kind of image, you can guide your needle to the top of the hill, and you will reach easily your facet joint. You can use as well this device, the ultrasound, to make some diagnostic. You can see arthrosis, you can see shadow when you have liquid at the facet joint as well, and you can use some injections or the pulse radiofrequency as a procedure to relieve your patient. And as you can see, you can also, when you are there, you can treat several levels, and that's what we are thinking and doing with our patients and noticing better results with the pulse radiofrequency for the spine. We thought that when we treat the level under and above, we may notice some better results with that. And you can reach as well, as you see here, with your cannula. You can put it a little bit down over there, and you can hit the neuroforamen. And you know, with the ultrasound, you have the measure of the distance of where you are, how deep you are going. And we usually make that measure before, and then you put our hand on the video lysoscope to know if I to go further than that. And with that, we're just in the entry of the neuroforamen. And I know that we are not that precise or so precise as the X-ray does, but the question here, when you're using the pulse radiofrequency, we know that we have a bigger and a larger electric field, larger than the continuous one. So then, shall we have to be that precise? That's the question and discussion we can put here. Because actually, maybe not. Maybe if you're just near to the nerve, could be good enough to make your procedure. Because actually, you're making an electric field between the tick tip and the earth plate. And we have some papers showing the fatalities of ultrasound guidance for having pain for cervical as well. This paper is quite nice, but actually had great illustrations in how to do the procedure guided by the ultrasound. But what I used to do is just as I do with the X-ray, with the CR. I go lateral, I put my transducer here in the lateral part of the cervical, and you will see the facet joint and the medial branch easily with the ultrasound. Here you can see a safe and sound facet joint with, when you have the top of the heel as well, you have the facet joint, and down the valley you're going to see here the medium branch. And sometimes you find some osteophytes and some arthrosis like that, like the seems that the facet joint is like a crocodile mount like to bite your needle. And for the knees we have some good indications as well, as we saw before with Professor Fipiades yesterday, and some indications for like Calgren-Lawrence 2, 3, and 4 osteoarthritis, and for those patients who don't want to go to the surgery or have some clinical complications that made him not to go to the surgery. So there, I put some suggestions in how I use the pulse radiofrequency for the knee, and you see under the, you can also combine doing the genicular nerves as usual with the interarticular approach. The genicular nerve, as we've seen yesterday, we can use the usual approaches for the medial superior, the lateral superior, and the medial inferior one. And you have to be concerned about your hand. We are starting to use the ultrasound to do this kind of procedure. You have to be concerned about how your needle is going to be and how your transducer. So you have to pay attention in both hands and screen to be aware in the direction your needle is going. So this paper shows us exactly how to use the ultrasound to guide these procedures at the knee. It's for the thermal radiofrequency, but it's the same point. You can adapt it for the pulse radiofrequency as well. It is quite interesting procedure with the ultrasound, because you can make the diagnosis of your patient in the clinic. You can see the joint, you can see osteophytes and other alterations of the joint, and then you go down there, you see the curve. When you have the curve down there, you are probably near to the nerve. You can put your Doppler on, you will see the vessel just beside of the nerve to be exactly the point. And that's quite interesting paper, because I like it very much, because actually he made a comparison by using the 3 genicular nerves and just the saphenous nerves point, the saphenous branch, with similar results. So then it's quite easier, and you can do it much more comfortable for the patient with good results. We try to do that in our practice. We have done in this paper they've done for 115 patients. We have done in 30 patients with similar osteoarthritis in both knees, and we have good results using just the saphenous approach. It's an X-ray guidance paper. As I am an ultrasound fan, I adapted to the ultrasound, and it goes like that. Because actually you can see here the patellar tendon and the end of the patella bone, and you just put your needle under your tendon going from medial to lateral, and you can make your procedure safe and sound. And it's great because actually at the end of the procedure you can pull your needle a little bit over and put your hand up and go inside of the joint, and you can medicate or combine with another pulse radiofrequency interarticularly also. For the shoulder, we have some good indications for the shoulder as well. We have Professor Hohoff with huge experience with the shoulder for frozen shoulders and other kind of painful complaints. And we can do, as usual, with topographic and anatomic parameters, as we've done for blind suprascapular blocks. But I suggest here that you can use the ultrasound as well to make the procedure a little bit safer. You can, as usual, you can use your ultrasound up here, but for those who are starting to use the ultrasound in this kind of procedure, I suggest a little trick, because actually you can go at the dorsal position of the scapula, and you will have the exit of the suprascapular nerve there. And you can make with the same function, you can make from lateral to medial, reaching the reaching the suprascapular nerve exit, and after that you just change your transducer hand to lateral, and you go from medial to lateral, and you will have this image here, and you can go with your needle interarticularly. And what I have noticing that we have been receiving good results associating the suprascapular with the interarticular application, and I have seen better results making it combined. So you can see the needle, you can go inside of it using the ultrasound. It's quite elegant, because actually you go with your needle without scratching the cartilage in the head of the humerus. You can see the trajectory of your needle, by the way. And other more simple procedures like the acromioclavicular, we know that it's a usual complaint of patients from arthrosis, and it's quite easy to do, it's superficial. You can go inside of that joint guided by the ultrasound. And even for the carpal tunnel syndrome, I believe it's this kind of procedure over there. If you can see, I can go as well, not just as usual from ulnar to radial. We can make the procedure a little bit easier and safer if we go from distal to proximal, and we put our needle just above the nerve, and we can make associate with some hydroexcitation at the end. For the hip, we have some good indications for the hip. We know that it's a big joint, and big joint may not respond as well as small joints with the pulse radiofrequency. Maybe we need to combine with some continuous radiofrequency when the patient is full of pain. But we can assure that it's the joint that benefits most by using the ultrasound to guide your procedure, as we have the vessels and the femoral nerve there, and you have to be aware about those structures. So the great point here is that you have to be aware always with the bone floor. We put your transducer in the pelvic, and you have to always just go with your needle if you are seeing the bone floor. That's going to make you safer to go to your procedure. Otherwise, you could be entering the pelvic cavity. So you can make it over here, retract your needle a little bit here, and go over here also. You're going to reach the femoral, lateral, and medial sensitive branches. The obturatory one, you may need the X-ray to go safer. But we are looking in our practice that maybe the obturatory nerve is not quite necessary to go. It's a little bit difficult to go there, and maybe it's not so necessary, because a huge part of the femoral head is innervated by those femoral sensitive nerves. And then usually the patient had a good result using just the femoral branch and the interarticular approach as well. And you can go just as you go for injection. This is an approach just for hyaluronic acid injection for the hip. You can go like that as another trick, and try to make things easier and safer for those who are starting to do. So you can pull your needle a little bit up, down your hand, and you can reach this area with your needle. Unfortunately, I don't have that video, but you come with that needle here, you come over here, and you are going to reach the lateral femoral sensitive nerve and the interarticular approach as well in an easy and safer way. We have some papers showing the PRF and hip. We don't have a lot of paper of that, but we have some. And what you're having in mind nowadays is that those kind of patients, they are in osteoarthritis situation, they are elderly, so they are stimulating cartilage, prostaglandin reabsorption. They are releasing the metalloproteinase. and ventricular oxygen production. So the cell yield is not in a good situation for proliferation, differentiation, and particularly problematic in advanced aged patients. So in those kind of patients, with this kind of cell yielded situation, we maybe benefit them with combined procedures. And that's what we thought in that review that we wrote last year, putting some mechanism of action as a synergistic effect between ultra-radio frequency and some orthogonal use as well. So we know that we have acid hyaluronic associated with that, like Professor Filippiazzi showed yesterday with good results, and we have to be aware that those patients, we have to put forces together to get better results. As Professor Sevenser said in his presentation, we have to be concerned about the patient-centered medicine, and that's what we are trying to do. That's our course in Brazil, and we are very happy and proud of it, because actually we help colleagues to learn some techniques and approaches, but the most important of all, we can offer to patients who cannot afford and pay for treatments, high quality and technological treatments as well. That's it. Thank you. Thank you very much.
Thank you very much, Dr. Tenenbaum, for this very instructive and fascinating use of PRF. Yes, you explained it. Are there any questions in the audience? Olaf? No questions? Yeah.
Thank you for your lecture. Ask about what is the effect of voltage from 6 to 100. If increase voltage to higher level, is more be effective pulsed radio frequency? This is the first question. If increase the voltage.
The voltage?
Yes.
You usually use the 45 voltage.
Yes.
Not more than that.
But
sometimes 50, sometimes 60, but usually for joints,
there
we
is,
use 45.
there is paper when increase the voltage of pulsed radio frequency is more effective, more than the low voltage.
Next lecture, I will tell you.
Oh, okay. Professor Schwab will show you, but I used to use those kind of parameters and adjustments that I showed you.
Okay, the voltage and duration of pulsed radio frequency.
Yeah.
This factor affect the effectiveness of radio frequency. There is a lot of factors.
Actually, we don't have a standardization of that yet. You know, I used to choose depending on how the patient is painful or not, and the grade of the osteoarthritis involved. So, I put there just some suggestions. That's what I've been doing. But I usually use the 45 volts, 5 hertz, 5 milliseconds pulse width for 8 to 12 minutes. That's the medium for joints. But you can adjust as you want, exactly. But you have to be aware to not putting high voltages.
But anymore, the pulsed radio frequency is not accepted by insurance everywhere.
No, I don't know. Here.
Here in the US, it's not accepted by insurance.
Yeah. Maybe you can talk this for particular practice in your clinic. I believe that could be the better way to use it. You know. In Brazil, we have some problems with that as well, not only in the US. And I used to use it as a private in my clinic to benefit the patient. That's the point of it, because as it doesn't hurt, the patient can support very well the procedure at the clinic. You know?
I have a remark about USA. When we started pulse radio frequency in the late 90s, many podotherapists were doing fasciitis plantaris with pulse radio frequency. And the cost went sky high. And then the insurance company said, is there evidence for it? There was no evidence, so no pulse RF. No differentiation. And then many colleagues went over to cryo again. That's why. But I think with all the new data, you could go again to the insurance companies and ask whether they change their opinion.
That's why I said at the end that we have to focus on patient-centered medicine, because that's the point of it. You want just to benefit the patient, then you have to use whatever you have to. But actually, you have some insurance questions.
Thank you very much. Are there any other questions? Then thank you, Dr. Daniel George.
Thank you.
And we will